We're ready, Chris? Okay, well, I'm Steve Higgins, and I want to say good afternoon to everybody who's online and here in person, and welcome you to the April lecture in the Vermont Center on Behavior and Health lecture series. We do want to have you participate in the Q&A, including those who are online. So please send in your questions. And as you can see on the slide behind me, we have Jessica Cook with us today. Jessica is from the Center for Tobacco Research and Intervention at the University of Wisconsin School of Medicine in Madison. So for anyone that doesn't know, that's kind of one of the meccas in tobacco research. And I mean that truly. They do great work, and you will see that today. And so I'm going to have Eli Klemper come up and do a more formal introduction of Jessica. So Eli.
Hi, everybody. Thanks for joining us today. Very pleased to introduce Dr. Jessica Cook, who will be giving her talk entitled Engaging Our Strategies for Engaging Those Not Ready to Quit an Effective Smoking Treatment. Jessica is a tenured professor at the University of Wisconsin School of Medicine and Public Health. She received her PhD in clinical psychology at the University of Illinois, Chicago, and completed her postdoctoral fellowship in Seattle at the VA Northwest Network Mental Illness Research Education and Clinical Center. Jessica currently serves as an investigator at the University of Wisconsin C-Tree, Steve mentioned earlier, and the William S. Memorial VA, where she directs the Veterans Tobacco Research Group and co-directs the VA Interprofessional Advanced Fellowship in Addictions Treatment. Jessica's program of research has been dedicated to evaluating innovative smoking treatments, extending the reach of evidence-based interventions, and improving our understanding of dependence and motivation to quit as mechanisms that drive tobacco addiction, with a focus on effectively vulnerable populations. Jess has a series of studies that have been particularly instrumental in developing interventions for people who are unwilling or unmotivated to quit smoking, as well as understanding anhedonia as a particularly important motivational symptom of tobacco withdrawal. Her work has certainly shaped the way that I think about tobacco research and has done so for many others in the field as well. So I'm very excited to have her talk today. So welcome, Jessica.
Thank you, Eli, for that really nice introduction. Well, it's a pleasure to be here. Really had a really nice morning talking with some of you, and I'm really excited to share my work. I forgot to create a disclosure slide, but I have no disclosures. So, smoking remains the leading preventable cause of death and disease in the US, and it still sort of astounds me that it kills close to 500,000 people every year. I mean, that is staggering. And smoking results in an average of 10 to 20 years of lost life. So the challenge that many of us are working on is what can we do to reduce and really hopefully so that the current generation and future generations don't continue to die from it. I mean, the good news is that we've made tremendous progress. Smoking prevalence is down to about 11.8% in 2023. What sort of astounds me is how kind of steady the decline has been. If you look at the trajectory, it's really remarkable. And you think about all of the variables and the factors that have affected this decline over time, and the rate is very, very steady. And I kind of wonder why that is. All the different, regulatory interventions and times that we develop new drugs and treatments. So that to me is just fascinating. If we continue on this very steady decline and this trend, smoking would be eliminated by 2050. So this is great, but we know that millions will continue to die, and especially disparity groups who are particularly affected by the harms of smoking. So, the question is, how can we bend this curve? How can we accelerate progress? It's funny because I must have made this slide quite a few years ago because I have us eradicating tobacco in 2025. I was feeling very hopeful. I don't think that's going to happen. But you get the point. What can we do to accelerate our progress? Of course, I think this is sort of a multifaceted approach. We need regulatory efforts, taxation. We need prevention efforts. We need to keep developing better treatments. And I think we need to really focus. We have a lot of treatments that work, but really focus on connecting more people with the treatments that work. And for me and people at Center for Tobacco Research and Intervention, I'll just call it UWC-TRI from here on up. One strategy we've looked at is connecting more people with effective tobacco treatment in healthcare settings. Healthcare settings are a really ideal venue for treating people who smoke because at least 80% of people who smoke visit a primary care physician each year. So it's really suited for treating tobacco use. Despite this, there's a lot of research that shows that only about 5% of patients who smoke leave their healthcare visit with recommended treatment for their smoking. And by recommended, I mean, maybe more people leave with a prescription for NRT, but only 5% are leaving with a combination of being set up with counseling at a quit line and medication. We see this in both the VA and many other healthcare settings. So, it's kind of a head scratcher. It's really the ideal venue for treating smoking. And why is this happening? So I'm going to share some research and thoughts on how we might improve delivery of smoking treatment in healthcare. And I think there are really two important points where I think we're losing people. And so one is just, this is obvious, not enough people are entering treatment. They're not starting it. So we lose people there. But then the second juncture is when people do start treatment, they tend to just disengage from it really quickly. They don't stick with it, or our health system doesn't support them sticking with it long enough for them to achieve long-lasting abstinence. So I'm trying to represent this with this pipeline. So it sort of represents the flow of what I think of as patient desire to change their smoking. And you'll see these two junctures. There's stage one. We want to open that up. We want the people to flow through so they can quit and attain better health. But we've got to get them to start treatment, or this can't happen. And then once they start, we need them to sustain treatment. And by that, I mean, when they relapse, we need to re-engage them, or we need to say, are you feeling demoralized? Is there some other way, something else you could work on, another goal that might be meaningful with your smoking to get you to the point where you're ready to quit? So we need to somehow figure out a way in our health systems to sustain that engagement. So we're going to start with stage one and talk about two barriers. And I'm sure there's lots of barriers for starting treatment, but I'm going to focus on two that I've been focusing on and others. So one barrier to getting more people to enter or start treatment is that actually the vast majority of patients at any given clinical encounter will tell you, I'm not ready to completely quit right now. In fact, 70 to 90% when they're offered cessation treatment will say, I'm just not ready to quit. Because most healthcare centers are offering cessation. Are you feeling ready to quit in the next 30 days? And then you get people started. So what happens when we have a cessation only approach is we're really restricting the population of patients that can be treated. And so I'm going to talk a lot about that today. So I think it's really vital that we develop effective treatment for people not ready to quit, and people are really working on that. I'm going to talk about those treatments, and then make sure it's offered too. So we need to develop it and make sure it's being offered in healthcare settings. I'm just going to talk a little bit about my work and others' work in this area, treating people not feeling ready to quit. Back when the guidelines were written, there was pretty limited data on treating people not ready to quit. But there was enough evidence to make a few basic recommendations. So back in 2008, the guidelines did recommend using pre-quit NRT. I think this was based on a meta-analysis of only 5 studies, and MI, so specifically the motivational 5 Rs. I don't think it really gained a lot of traction. It just wasn't being used. But then in the past 15 years, there really is more growing evidence for offering specifically smoking reduction treatment. It's another goal for people who just aren't feeling ready to quit. And so reduction treatment, for the most part, typically involves using some form of NRT, typically patch or mini lozenge or gum, combo on occasion, I think, plus counseling, a behavioral reduction counseling focused on reducing. And the goals generally, I don't think there's any uniform reduction treatment, but the goals generally are to make incremental changes to people smoking that we hope will ultimately lead to quit attempts and abstinence. So this reduction treatment isn't really a harm reduction approach. I think it creates a context to allow people to learn skills and feel like they can be successful at making some changes. And I'll talk about some of those mechanisms in a little bit. Because the ultimate goal is we still want people to make quit attempts, but I think offering people a stepping stone, a place to start, makes a lot of sense. And we have some data to support that it does promote abstinence. Strategies can involve using NRT to replace cigarettes, decreasing smoking heaviness, so cigarettes per day. People could work on increasing the time between cigarettes, reducing exposures to environmental smoking cues. And if you can imagine, if someone were to make a lot of these changes while reducing, it's actually setting them up to potentially be more successful with quit. So I decided just to share sort of 4 key takeaways from this research instead of really getting down into the weeds. So one key takeaway is that in general, reduction treatment increases the reach of tobacco treatment. So we seem to be able to induct more people into tobacco treatment in healthcare settings by offering this alternative to cessation. Sometimes you offer cessation first, and when they say no, then you offer reduction treatment, or you can offer them side by side. But it looks like about 25% more patients enter smoking treatment when reduction treatment is offered, in addition to cessation treatment during primary care visits. So that's not a small number. If you can connect 25% more of a patient population in a healthcare setting into treatment, that's a big deal. Now, not all of those people are going to quit, but I still think there's incredible value in just getting people familiar with NRT, right? Because often people don't adhere to NRT when they quit. So I think just getting people even just practicing using NRT and figuring out how it works for them is really valuable. Takeaway 2 is that in general, NRT increases quit attempts and abstinence in those who initially say, I'm not ready to quit, but I'm willing to do some reducing. There's a Cochrane report and a nice meta-analysis by Moore and colleagues that shows that NRT relative to placebo or NRT versus no NRT results in reduction and higher abstinence. Research from CTRI, we've really found evidence that short-acting NRT tends to be a little more effective. Gum or mini lozenge, I think it's more of a behavioral substitute. It's something you can use while you're currently smoking, you're working on reducing, and you can pop in a mini lozenge when you're trying not to smoke in your car. We actually found in one study that a little bit of a iatrogenic effect for patch, and I don't totally understand that. So we've kind of just moved towards short-acting NRT. I will add that although there is a significant effect of NRT for this population on quit attempts and abstinence, the effects are modest. But the best we're finding is generally self-report rates of about 10% at 6 months in a year. So, again, this is a population who said they really didn't have an interest in quitting. So it's something, but I would love to see us drive up that effect. That caveat. But that doesn't mean we shouldn't be using it or healthcare systems shouldn't be using it. And then I would just add, I'm sure everyone in this room is aware of this, but providers sometimes feel uncomfortable about prescribing or giving someone NRT while they're currently smoking. And across the board, research has shown that the side effects of using NRT while smoking are really minimal. And it's considered a really acceptable risk, of course, compared to just continuing to smoke. So I thought I would throw that out. And finally, we've really learned through a couple of trials that for those using reduction treatment, having cessation treatment available really improves the likelihood of abstinence. So what this would mean is if someone enters reduction treatment and they're using mini lozenge and reduction counseling, and they decide, I want to quit, it would be important to transition them to medication that works for cessation, Brenaclin or combo NRT, and then switch the focus of counseling to cessation. Now, this is a little bit of a, these data are affected by self-selection, but we know in our trials, people who make quit attempts when they're receiving reduction treatment, who take us up and they use that cessation treatment, are far more likely to quit than people who just continue using the mini lozenge and not getting cessation counseling. So like 42% versus 10%, that's a huge difference, 25 versus 16 at 1 year in another study. Again, the availability of cessation treatment wasn't randomized, so a bit of a self-selection bias, but I think it's a safe assumption to say that it's important to have cessation treatment available when someone decides they want to quit. So I feel kind of comfortable making that recommendation. And interesting, a lot of the prior reduction studies haven't made a cessation treatment available. People have just quit using their reduction level, NRT, they haven't transitioned. So I think we can boost abstinence rates by making sure we're there to meet people when they make that transition to quitting. Just wanted to highlight some great work by Eli and John. So they conducted some important mechanistic work for people who weren't ready to quit. And these variables are all potential treatment targets. So in terms of predictors of making a quit attempt, decreased smoking heaviness is important, decreased level of dependence, and an increase in quitting self-efficacy, right? So people are making these changes, and what I would assume is it's making them feel confident in their ability to quit. Like I'm able to cut back. I bet I can make a quit attempt. And in terms of predictors of 6-month point prevalence abstinence, we see, again, decreases in cigarettes per day, which is kind of a consistent predictor of abstinence, decreasing pros of smoking, and then an increased intention to quit. And, I think in general, as a field, it's important that we take a more mechanistic approach, so we can develop treatments that really target these mechanisms. And these are the intended targets of our reduction and our, pre-quit NRT. Anyway, this was a really great study. All right, so we've talked about developing treatment for people not ready to quit, but the next issue is making sure it is offered to them, right? So at this juncture, we can have the best treatments in the world, but if it's not offered to everyone in a health system who is identified as using tobacco, then we're missing an opportunity. So now I'm going to talk about proactive outreach as a strategy for making sure everyone is offered tobacco treatment, regardless of their motivation to quit. So, the most common model for offering treatment in healthcare systems is the point of care model. And this means that patients get offered treatment when they attend a clinic visit. And when this model works, it works really well. I think it's really powerful to have your physician or a nurse, someone who knows your health history, recommend that you quit and say, this is really going to help you with your diabetes. That's a really powerful and excellent model. Unfortunately, many people get missed with this model. So we know many people don't regularly visit their healthcare clinic, especially those with socioeconomic disadvantage, minoritized populations, and this can lead to inequities in treatment offers and treatment use. And of course, we just have to acknowledge that clinical burden is very real. It can make it very difficult for providers to offer and provide treatment. So I view proactive outreach as a way to sort of extend this important point of care model. Some people get missed, and we can layer on other strategies to make sure we're reaching and educating everyone, all patients, about treatments that are available to them. So I'm going to use an ongoing VA trial. It's fully recruited that I'm running at the Madison VA. And I'll tell you a little bit more about the design in a few slides, but that's not important for this first part because I'm really going to talk about recruitment and a strategy that we use to basically broadly advertise treatments available at the Madison VA. So what we did was we utilized, it's called the VA Health Factors Database, to identify patients who are identified as using tobacco at the Madison VA. Then we sent out a simple postcard, and I'll show it to you in a minute, letting veterans know their treatment's available for all veterans who smoke, including those who aren't ready to quit. Proactive outreach, of course, has been used in other settings. I don't think it has ever been used to advertise treatments for people not ready to quit. And of course, in general, we know that proactive outreach increases reach relative to point of care models. And I did something a little bit different that we had an incredible response, and I'm writing a grant to test this. But with this proactive outreach, we offered a simple contact incentive, just to simply call and learn about your options. So we weren't offering an incentive to enter treatment or to make any changes. So this is, veteran VA colors, the VA logo, and we were able to use a postcard because we said, do you smoke cigarettes? So technically this could be sent to everyone. I wasn't sure if the IRB would let us do this, but they did. So you can receive $40 just for calling the Madison VA to hear about resources for all smokers. That's not non-person-centered language. I wrote this a long time ago, including options for veterans who aren't ready to quit, such as treatment or a paid research study. So we told them about all their treatment options, not just a study. The call will take 10 minutes. And then importantly, you do not need to quit smoking or use any treatment to receive $40. So we thought we were going to get tons of calls with people take the money and then they don't do anything. You'll see the vast majority of people who called us enrolled in treatment. Like, I was stunned. I thought, oh, we're going to lose a lot of money. And we didn't. So here's the general flow. We mailed out approximately 10,000 postcards. So those are all the people identified as using tobacco. And they called us. We did a screening enrollment call, but we wanted to siphon off people ready to quit because in our trial, we're enrolling people who aren't ready to quit. So we asked whether they're interested in quitting in the next 30 days. And if so, we referred them to the VA Tobacco Treatment Clinic, a really great resource that uses great treatment. If they refuse cessation referral, we screen for interest and study eligibility and randomize to their study condition. And I'll tell you more about the study when we get to the next phase. But just wanted to share the enrollment numbers. We received 1,400 calls. So I think it's pretty good that 14% of this whole population came to us. So typical proactive outreach, you get the list of 10,000 and then research staff call every single person. And then you make, like Steve Fu from Minneapolis VA. They called like every person up to 6 or 7 times. So it's and I have a very small team, and I actually knew there was no way we could pull this off. And then I also thought, I don't know if how scalable that is. I don't know of many health centers who have the staff resources available to just call people and keep calling and calling. So 14% of the population called us. And then of those 1,400 who called, we reached almost 90%. Again, this is a team of like 1.5 people. It's a very small team. And then of those people who we reached, 36% wanted a referral to the VA Tobacco Treatment Clinic. I could not believe that. And then 40% entered our Help with Motivation study. And it was a study for people not feeling ready to quit, where you could receive quarterly motivational interventions and treatment offers. And so that means 948 people entered, and that's a 9% entered treatment at the population level, the Madison VA population. So in terms of population, other, I think, studies have seen these effects too, but I should have brought it's like this little postcard. It generated such interest and high rates of treatment entry. So again, 14% of the total population of the Madison VA responded to the postcard by calling just to learn about their options. We think, and I'm going to test this in a grant that I'm submitting in a month, offering an incentive to call a tobacco treatment coordinator to learn about treatment options may increase treatment engagement relative to no incentive. So I'm going to do a study where I basically send that postcard with and without the incentive, but I'm going to do varying levels, 40 versus 20 versus 0. Because what if we can get the same response with 20? And I think the other thing it's confounded with, that postcard, is it's advertising treatment for people not ready to quit. So I'm going to do a 2-factor design. Postcards just offering cessation treatment versus postcards offering cessation treatment for everyone, or smoking treatment for anyone, regardless of whether you're ready to quit, then cross with varying levels of incentives. Again, this is just about treatment engagement. This is, can we get people to enter treatment? I'm really excited about this. And then of those we reached, 76% entered treatment, 36, of course, entered cessation, and 40% entered treatment for people not ready to quit. So offering treatment for those not ready to quit really more than doubled treatment entry, because we offered cessation treatment first in people who, it's possible people remembered that there was other treatment available. So you could say maybe we're siphoning people into motivation phase treatment for, who might have entered cessation treatment. But for the most part, I think we can safely say that offering motivation phase treatment, it's treatment targeting people not ready to quit. I think it about doubled treatment entry, which is really, really cool. So I think for stage one, at least that's what I'm focusing on right now, is making sure we're casting a wider net. We should have treatment options for everyone. And actually, I think we should have treatment for people who don't even want to make changes. Just try out NRT. Just get familiar with it. That's okay. It's safe. And use a variety of strategies, proactive outreach. We still want to rely on point of care, but make sure we need to find better ways to connect people with these treatments. But let's move on to time two. Doing okay. So stage two, when we do get them in, how do we sustain them? How do we keep them in treatment? Because it takes a lot of attempts. And now we're adding in a new phase where people are working on reducing or changing some smoking patterns. So you really have to stick with those people as well, because we have to be ready to really connect them with cessation treatment when they become ready to change. So what do we do in our health system to sustain their engagement? And I'm going to look at a chronic care approach. So, of course, a barrier to sustaining treatment engagement is that, so tobacco dependence, it's a chronic relapsing disease. We all know this. And clinical practice tends to focus on a single course of smoking treatment, even though we know most people relapse back to smoking. Follow-up after treatment occurs very rarely. And so when people relapse, we miss an opportunity to re-engage them. And there's a new clinical trial that actually shows that when people relapse, and this was in a big healthcare setting, this is at CTRI, people who were encouraged to re-quit immediately were far more likely to achieve abstinence than people who didn't. And actually more so than people who actually just worked on kind of a reduction type treatment for a while. It's best just to keep them going where they have the momentum. So we don't want to miss those opportunities. Of course, tobacco dependence is a chronic disease. It typically requires multiple attempts to quit with repeated interventions. We want to treat smoking like we treat hypertension or diabetes. It shouldn't be a choice. I see you smoke. What would you like to work on with your smoking? We have a variety of options. If you could quit, if you feel ready, you could just make some changes, and you can even choose what changes feel important to you. I mean, I think the big thing is you want them to get confident, more confident, and increase self-efficacy, and just start using medication. So they needs to be addressed regularly. And again, importantly, as I said, we need to address it regardless of motivation to quit. So the trial that I told you, that gave you the recruitment data for, that trial was testing an enhanced chronic care intervention for veterans who said, I'm not ready to quit. And I'll show you the design slide in a second, but just so you understand this intervention, I thought, well, this is a population that we have some evidence that from some older data that this group of smokers, they have more risks for cessation failure. They're reluctant to make quit attempts. They have report a history of behavioral health issues, more likely to drink alcohol. So I thought we need a chronic care approach to keep working with them. And so it's 2 years of ongoing motivational interventions that occur every 3 months. It's pretty frequent, and provides a lot of interpersonal support. And we're trying to promote readiness to change. But embedded in this, we're always offering treatment. Cessation treatment, which was combination NRT and counseling, and then we changed reduction treatment to cessation or to changing smoking patterns, because for some people, and Eli and we're working on a project right now, and there has been some evidence that reduction doesn't work for everyone. I think it can be sort of demoralizing. So we wanted to give people an option. There are a lot of important patterns you can change with your smoking. It can be a way to gain some control. I know you're not ready to quit, and that's no problem. And we had them they could choose gum or mini lozenge, doesn't really matter. And then they had reduction to support their changes. A lot of people reduce, but a lot of people started out with other changes and then moved into reduction. So this 2-arm RCT comparing enhanced chronic care to standard care. It's fully enrolled and people are in follow-up now, but you know, we've passed the 1-year follow-up point. So we have a lot of data at this point. We'll be looking at abstinence, of course. What I'm going to focus on today is interim analyses, but use of treatment, cessation treatment, total treatment use, and changing smoking patterns, CSP, over 2 years. We'll look at cost effectiveness too, eventually. So in terms of treatment entry in the standard care group, and I should say standard care, they get 1 offer of cessation treatment a year, what you would typically encounter in most healthcare settings. 10% have entered formal cessation treatment. Great, and we actually provide that in our lab, but it approximates what happens in the VA tobacco treatment clinic. In enhanced chronic care, we've had incredible treatment entry. So 47%, almost half the sample entered changing smoking patterns. That's great. 30, and remember, when people entered the study, they didn't have to agree to do anything. They just had to agree to take calls and be offered treatment. 32% have entered cessation treatment. 60% have entered any treatment. There's overlap between changing smoking patterns and cessation treatment, because a lot of people do both. And I don't have these data today, but many people do multiple rounds of treatment. They love it. They're hanging with us. And I think this is what I'm most excited about, that last line, that 57, so almost 60% use changing smoking patterns prior to transitioning to cessation treatment. So that's the hope, is we want to convert people from working on reduction or changing patterns into quitting. So I'm kind of excited about that. And then I also just pulled some data for this talk on sustained. So because in these data I was looking at whether people entered at least 1 episode of changing smoking patterns, at least 1 episode of cessation treatment, but wanted to get a kind of an indicator of sustained engagement. Are people in enhanced chronic care using more treatment? And they definitely are. Enhanced chronic care participants are attending an average of 5 phone counseling sessions versus less than 1 in the standard care group. And I use this to just power another study. And even we only needed 50 people to find a significant difference here. So it's very different. All right, so I want to talk about some takeaways, and then I love getting feedback and thoughts. I'm really kind of thinking about kind of the direction of the field and what we can do to start to address some of these junctures and these gaps. So would love to hear your feedback. But I think proactive outreach, offering a contact incentive to call to learn about treatment options, may increase entry into tobacco treatment. That wasn't randomized, but I can compare it to a lot of other studies. And I think that contact incentive was huge. And again, I'm submitting a grant to start to formally test that. I think because the contact incentive, I think it doesn't decrease intrinsic motivation, because you're not paying someone to do something difficult. If you think of self-determination theory and you think about the times that you want to apply rewards to something, you sometimes see when you pay someone for treatment, or you pay someone for abstinence, as soon as you take the incentives away, people relapse. And so I struggle sometimes with incentives, but I thought, well, we are just offering something, an incentive to get them to call and learn about their choice. I don't think it decreases their autonomy. I feel like we're telling people, just give us a little incentive to learn about all of your options. We did some qualitative interviews about the postcards too, and all of the veterans, they said things like, I love you. You gave us money. I mean, and they said it put them in a happy mood. And there's also some research on mood that shows that when someone's in a positive mood state, they tend to be more open to information coming their way. Now I'm really digging, but I thought, why was this incentive so effective? Anyway, oh, and the other thing we learned from those interviews was that people who entered cessation treatment said they probably would have responded without the contact incentive, because we just hit them at the right time. They got the postcard when they were thinking, I think I'm getting ready to quit. But the people who weren't ready to quit and entered the motivation study said, I probably wouldn't have responded without the contact incentive, which I think is really interesting. And I'll be able to answer that question with a factorial design. Offering treatment for all people who smoke, regardless of their motivation, increases treatment rates. I can confidently say that. But I really think we need to continue developing more effective treatments for people not ready to quit. Alternative products, e-cigarettes, BLNCCs, other innovative strategies. I'd love to boost that effect on abstinence. And I think they're that are just more reinforcing than NRT. I still think we should use NRT, but I think we should be exploring other avenues for sure. You know, and Eli's doing a lot of great work in that area. And I think using a chronic care approach, and one that, you know, I think ideally includes some supportive elements, some really, I don't mean complicated MI, but brief MI strategies, offering multiple treatment options for treating people not ready to quit, increases treatment on treat. And it seems to be sustaining engagement relative to standard care. Again, those are interim results. Will be done in about 6 months. I'll end with this model. And, you know, I think by thinking about these junctures where we lose people, in being sort of strategic, I think we can hopefully increase the flow of patients who enter treatment, kind of just stick with treatment for long enough to quit for good. And then, you know, ultimately we want people to achieve better health. Thank you.
We have questions in the back here.
So I thought the advent of the e-cigarettes and the vaping and all that business was supposed to replace cigarettes by providing the nicotine, but without the carcinogens. But it seems like they're getting a bad rap lately, that you're not supposed to vape and whatnot.
Yeah, I mean, there are different camps for sure. In my view, we need to be thinking about the relative risk of vaping or e-cigarettes. So I'm in the camp of kind of thinking that we need to really be thinking about the relative risk of e-cigarettes versus combusted cigarettes. And so, you know, in my view, e-cigarettes are a strategy definitely worth trying for using as an intervention for people who tell us they're not willing or ready to quit. Again, the risk of e-cigarettes relative to combusted cigarettes, we know it's less. I'm not saying it's zero. Well, I think there are some data showing there may be some. I think the jury's out. We need longer term studies. We need more time to go by before we really know. I mean, Eli, maybe you have more information on this. Is there some evidence that there's some negative lung effects, pulmonary effects?
Yes, I think e-cigarettes are not without risk. And ultimately, we want people breathing clean air. But relative to cigarette smoking, e-cigarettes are far, far safer.
Yeah, so that's the answer. The risk isn't zero for e-cigarettes, but it's far, far less than combusted cigarettes.
Great presentation. For the planned study comparing incentive levels, are you worried about cross-contamination? In other words,
because I'm writing the grant, so
yeah.
to address.
Well, it's just, you know, people who smoke tend to hang out together. And so if you have two people who are hanging out, let's say at the bar, exactly.
That is a big concern, actually.
And so, I mean,
That. Yeah, and it's interesting because in the VA, of course, everyone got an incentive, and veterans ended up handing the postcard around to their buddies who were veterans, and so they're talking, and we got a bunch of calls, people we just missed who weren't identified as using tobacco in the EHR, and they said, "My buddy gave me this postcard. He's in the study." So you're right. I'm not sure how to address that, but people will feel frustrated, I'm sure.
presumably, if you have the mailing address, you can keep a database for your research using the EHR saying if you send a postcard to
Make sure
Donald.
you two don't go to roommates.
Exactly. Or just, veteran X living at 123 Maple Street was offered the $40 incentive. And so when they call, say, hello, is this veteran X from that? But then you still need to deal with the fact of verifying what postcard they got or what condition they're assigned to. So
We'll have to verify, but we should have a record, right? So because people are going to be randomized, we're able to randomize at the patient level prior to consent, and they can opt out of receiving mailings. We're going to use some more modern strategies and use like texts and other sorts of notifications. But I think the postcard, at least for veterans, is working really well. So we'll have a record of what condition people were randomized to before we send it out. So we need to verify. That's a great point.
Your proactive outreach data are really exciting. And I was wondering about the time window for sending out the postcards. And if you had any data on, I guess you would have to ask them on how quickly
did we?
Well, how frequently and how quickly were people responding to the postcard?
Yeah. So we do keep record of all of this, and we did mail them out in sort of pulses. And people sort of came in and out of our data polls. It's going to be tricky at the end to figure this all out, but I would say people got up to 4 postcards and maybe as few as 1, 4, or 5, and maybe as few as 1. At first, I would say the first 3 times through that whole population of 10,000, we had a really strong response, and then it started waning off. Because at first I thought, well, maybe we're going to get the low-hanging fruit up the first time we get through the alphabet of all people, and then we won't get anyone. But as it turns out, people said, yeah, I got this 5 months ago, and I kind of I thought it was a joke. I didn't think it was real. The VA was going to give me money, but the third time I got it, I decided it was real. So we got, people saying stuff like that all the time. Or I just wasn't feeling motivated, or I was going through a hard time. I'm so glad you kept sending these. And you asked something else. I don't remember.
The people were responding, but it sounds like that varied. Some people were responding right away, and some people
people weren't responding. They didn't respond until they received a third mail out. Some people people generally would respond within a week, and we would just get a flood of calls. We could only handle 700 postcards at a time. Again, 2 people in my lab, my VA lab, because it's separate from UWC tree. It's all veteran data, so we have to keep that very siloed. And some people would hold on to their postcard for a year on their refrigerator, and we would get a random call at a time when we weren't doing a mailing blitz, and a veteran would say, this has been on my refrigerator for a year, and I finally decided to call you. So it's really variable.
You have another question. Those online, don't hesitate to send in questions or comments.
Thanks for your talk. That's great. I'm curious to hear, building off of the question around e-cigarettes, if you were to use e-cigarettes in your motivation phase treatment as part of that treatment, it occurs to me that, at least in the United States, e-cigarettes aren't really classified as treatment. They're not treatment in the US. So I'm wondering how you think it might differ from the model that, you've been using. So specifically,
right, it's not under the treatment for those that
would you
right.
Would you think that we should be, if you did use e-cigarettes in the model, presenting them as a form of treatment, as a way to treat someone who's not interested in quitting? Or is it more of a recreational thing that we can get people engaged with that then could eventually lead to harm reduction or anywhere in between that?
I mean, could it lead to harm reduction? Right. I mean, I think I don't think I would pitch it to people as something recreational. I think I might call it a strategy instead of a treatment, because it's technically not a treatment. I mean, I think it could be used as a treatment, but the packaging is important. I think I might call it, this is a strategy that might help you gain some control. And again, people who enter the motivation phase, they're telling us, we've done focus group, but they're telling us, I want to gain control. We also learned that when we offer reduction treatment or changing smoking patterns treatment, to never say, this can prepare you to quit someday. We were told it feels like a bait and switch. We don't want you to mention quitting when we enter a treatment that's not for quitting, because we feel like we're going to get tricked. And we especially found that in a Black population. And they said, we're really interested in gaining control. I don't want to quit, but I don't like feeling controlled by my cigarettes. So I'm getting off course, but I think I would use it as this is a strategy that can help you gain some control. You said you don't like smoking in these situations. An e-cigarette, you could use in these as a replacement in these situations. It can help you gain some control. So I think that's maybe how I would pitch it. I don't know. What do you think?
Well, I think that makes a lot of sense, and especially because e-cigarettes, by definition, are a lot more appealing than NRT and a lot of the other interventions we have. So it could, especially that stage one.
It's stage one, exactly. It's stage one, and then I'd want to get them from stage one into cessation, and then trying to sustain them. But I think I just had an e-cigarette. I told you an e-cigarette grant for this stage, get a terrible score at NIH. But what I propose to do is then if someone uses e-cigarettes for reduction and then they decide to quit, they can continue using the e-cigarette, because that's interesting. Does that help them quit if they continue to use the e-cigarette? But yeah, the packaging is important, and how we frame it and describe it to patients and to funders. Other questions?
An anonymous person asked, might harm reduction be a useful framing here? Which kind of builds on what you were saying, Eli. And secondly, there's a comment that says, I thought that research showed a lot of health dangers for e-cigarettes, and certainly it is considered very dangerous for adolescents.
It absolutely is, and we have to make that distinction. E-cigarettes are dangerous for adolescents, and I think we're talking about using e-cigarettes as a harm reduction approach for adult smokers. And I agree, e-cigarettes are definitely not without risk. We prefer that people do not use e-cigarettes, but when you compare them to the risks of smoking, we know we have a lot of evidence that it's a lot safer. So great questions.
I have a comment. I just love your idea of offering the incentive. And, I think we know that a lot of people who smoke have intentions of quitting. It's just they're not clear on when they're going to do it, or they're not ready to do it. And I would guess your incentive kind of brings it to a head a little bit. To do something. You incentivize taking action.
Just getting information.
Yeah. And then once that starts, it kind of snowballs and they end up joining.
Not feeling pressured. I'm having a positive conversation with someone who wants to empower me and give me information.
Yeah. And then the idea of, the ideas that are going through my head is other populations. So you did it with the VA population, but there are a lot of other populations who up on them. We don't really reach out and try and encourage them to smoke, yet we know that if they don't do something, 50% of them are going to die from that activity. So I just think it's wonderful. I'm big on incentives. I've had a lot of success with incentives. And so, I think you're very creative in the way you use them. I think if you want to do a what we call a magnitude study, that's great. But I can assure you, if you find out that you could do it for $20, someone's going to say, "Can you do it for $10?" And so, you know, yeah,
Fine. I don't think 10 is enough.
yeah.
I don't think so. And then the question is, would health systems adopt this? That's where the cost analyses would come in. But I think,
Yeah.
I mean, I've received notices from my health insurance company. I'll give you this health assessment. I mean, I feel like it's being done in healthcare.
Yeah, I agree. And you're putting it in the chronic care context or model, I think is brilliant. So for what is worth, you've got me thinking of extensions and applications. So I think it's really great work.
I was thinking, oh, this would have been interesting to use when we were trying to get people to get the COVID vaccine, because that was a population that was, I think they had a lot of fear. And I think a lot of that population was feeling very shamed. And I think offering people an incentive to say, we want to give you information to empower you. And it opens people up. Oh, that's worth 20 minutes of my time for $40. And then you have the opportunity to educate someone.
Eli and I published a paper on that very topic, because in the mainstream press, there were people who were associated with healthcare, and you would think would have been looking at the evidence, were saying that either incentives wouldn't work, or that they would be counterproductive, or you would need large amounts, like $1,000. And so we looked at what the literature is. There a literature on this? And there's already a literature that relatively small magnitude incentives could get people who otherwise would be reluctant to get vaccinated to anyhow, other question, Eli.
It's a quick follow-up to that question. Did any thought go into using postcards as the medium to reach out to people versus text message versus call versus email?
With the two wonderful women who manage my lab and are the health counselors, and we decided, well, we're thinking about when I get an envelope from my healthcare, sometimes just like throw it in the pile. You don't want to open mail, and we wanted something, it's actually a pretty good size. We wanted something that didn't require opening. A lot of this sample is older. They're veterans. A lot of them are retired. They tell us they love getting mail. Right. I mean, they're retired. But we just didn't want to use mail in an envelope. So we thought about using it's called My Healthy Vet, but a lot of older veterans aren't using My Chart, essentially. So we just thought, we'll try the postcard. And
I'm imagining translating this to a different population, and whether a postcard is the way to go, or other.
Well, I think younger. I think sending a text.
Maybe. Yeah. I can imagine. Yeah.
Maybe text. It could be something like, you can get this $20 or whatever to just learn about resources for people who smoke by hitting this button, and you'll get a call. So, I mean, that's what we're going to test. We're going to use postcards. We're going to use, and that's not randomized, but we can just informally see what sticks. And we're going to do it in community health centers. So a different population. So we'll see how the postcard works in that population. I think there was a raised hand over here, unless your question got answered.
Kind of touched on what I wanted to bring up. There's been some findings, I believe this was true, although Steve, feel free to correct me if I'm wrong, since you dived into the literature more than I did, but that large incentives for things like vaccines are actually viewed with some suspicion, which is the idea of,
I think actually, and I can see that happening. And that's why actually I think a contact incentive with no requirement, it's very autonomy granting. We want to give you options so you can choose. And this is the script we use when people call us. We want to give so you can choose what feels right for you. And I think it opened people up. We're not here to lecture you. Yeah. You know what's best for you. I just want to give you information.
But that's what I think is part of the brilliance of it. It's something I would expect to associate with the Netherlands or something. It's so open, like whatever you might want to do, it's your choice. Is just a breath of fresh air, I think, in the way we approach populations who clearly know that they should be doing something.
No, we don't want to talk down to that.
And many of them, we also know, have plans to do something, just not now. And it's funny how a little bit of money can get them to take some action, and then it looks like then it snowballs.
What you
So-
said, I mean, life, especially in a veteran population, they have a lot of stressors, and maybe that little incentive, it got their attention
Yeah, and
without the competing demands and stressors.
how many of us have things we should be doing, but we procrastinate, and then you do it and you think, I don't know why I procrastinated. It
Yeah.
wasn't so difficult or whatever. I think it's probably a similar phenomenon there, that they make the call and then they find out that, this sounds interesting and I plan to quit, or, I'll explore cutting down or cutting back. And I just think it's terrific.
Thank you.
Yeah. Other questions, comments? Anything online? Okay, well, Jessica, thanks for just what is said several times already, a brilliant lecture. And yeah, thank you very much.
Thank you. Yeah.